Hey class, it's Dr. Dorf. Quick lecture about anemia. I always start off saying quick and it winds up being a little bit longer than quick, or it's not quick. Anyhow, so hopefully you've had a chance to kind of look at the PDF that I posted. It's just a few quick little reference sheets that come from a text that I purchased after I had been out of school and in practice for a little while and found that I was still somewhat kind of struggling, not so much on CBC interpretations, but being able to pick up on some of the fine aspects of identifying different types of anemias, working it up, and getting it referred for follow-up if necessary. So that's kind of where this PDF came from. It certainly made my life easier once I got this down and utilized it in practice, so I figured you guys could benefit from this. So there's a nice big definition of anemia up here. Basically, kind of what it boils down to, anemia, and you strip all that away, is basically a decrease in the oxygen carrying capacity of the blood. That's all it really is. Maybe the most important thing to kind of take out of here is that anemia only occurs when the insult is severe enough to disturb normal homeostatic mechanisms and exceed reserves. So that's kind of important to remember. So let's kind of go back a little bit, and we'll talk about the conditions that are needed for red blood cell formation, and we'll talk about some of the clinical presentation of anemia. I'll start with that for just a second, because the clinical presentation, and this is a little more difficult than dealing with some of the stuff that we've previously done in terms of COPD, asthma, different GI issues. They have fairly straightforward clinical presentations. With anemia, not always the case. Clinical presentation is usually highly variable, and that's just because most anemias are usually very gradual in onset. Patients really don't tend to become symptomatic until things have significantly progressed. So a lot of times you're gonna get just a very vague symptoms. Fatigue is very, very common. That's why I usually check a CBC in the majority of patients that come in and say, hey, I'm tired, or I have fatigue. So you're going to see, although when you have an 88-year-old who comes in and says, hey, I'm tired, you still need to consider anemia, but in most cases it's, I'm sorry, I don't have a cure for the 80s, but anyhow. So fatigue's common, headache, decreased exercise intolerance, which you can see with other cardiac issues, even some respiratory issues, right? They'll also talk about tachycardia, maybe rapid heart rate. It's usually, in that case, a reflection of the decreased oxygen carrying capability of the blood. And it's just corresponding with how the body's kind of compensating. So those are some different things you can kind of look at. In kids, you'll sometimes see a report of just not doing well in school, not performing well, maybe difficulty learning. And patients who are at risk for, or who have already had, have a diagnosis of coronary artery disease, sometimes you can have these symptoms that are very similar to angina, when it can be an underlying fatigue. So that's kind of basically in terms of your subjective history. Physical exam, it also contributes very little to the diagnosis unless the anemia happens to be very severe. Because you typically have been trained maybe at bedside or at the undergraduate level that, oh, look for pallor. Pallor of the skin, mucous membranes. That's a very good indicator if someone's anemic. Yeah, maybe so, but in actuality, it's actually pretty unreliable. It's usually only when you see pallor and changes of mucous membranes when the hemoglobin drops to less than 8 grams per deciliter. So, elderly patients, individuals with coronary artery disease that are elderly, they may present with signs of heart failure, CHF. We just recently talked about that. So you're going to see some jugular venous distension. You may encounter rails. May have some GI issues, especially in a patient with chronic liver disease, right upper quadrant abdominal discomfort, presence of hepatomegaly. You can also see what we sometimes refer to as a hemic murmur, or hear that. Actually, you're not going to see it. It's early systolic murmur. So you have a patient who comes in, they've never had a murmur in all of their previous office visits, and all of a sudden you pick up a murmur. Check that CBC, see if that H&H doesn't happen to be in the gutter. But it's called a hemic murmur. Again, you're going to see that when your hemoglobin drops significantly. And it's primarily due in part to the increase in blood flow over the heart valves. In some settings of anemia, primarily you're dealing with like vitamin B12 deficiency. You may have some neurologic findings, some paresthesias. Something that we call stocking glove neuropathy, occasionally some balance issues, and in extreme cases maybe some confusion and mental status changes. So again, you're going to find that primarily in the setting of B12 deficiency. You may see some of those with folate deficiency, but you usually aren't going to see the mental status changes. Anyway, all right, and we'll get into that some more when we start talking about some of the specific anemias. But that's kind of a general overview in terms of subjective and objective clinical presentations. So, all right, we've defined anemia, conditions that are needed for red blood cell formation. So that's really what we're focusing on, what we're dealing with here when we're talking about anemia. You need to go back to your patho. You need to kind of remember how red blood cells are formed. There's some things that are kind of mentioned here. You need to know about the different components that make up the red blood cells, obviously. But you need a functional erythropoietin mechanism. Majority of erythropoietin source, it says 90% renal and 10% hepatic. That's why you see patients who have chronic renal issues, patients that are on dialysis, end-stage renal, they often need supplementation. They need to be given erythropoietin. So you also need uncompromised DNA synthesis, and this can be impaired in the presence of chronic inflammation, especially in the setting of an infection. And then where else do we see chronic inflammation? We see it underlying autoimmune disorders. So look out for that. Hemoglobin synthesis that's unimpaired by lack of iron, vitamin, or globin production. So basically, people need to have adequate nutrition, getting it from iron, B vitamins, vitamin C, protein. Most of that's going to come, of course, through just a daily diet, maybe multivitamin. You're also going to need an intact environment for bone marrow. A lot of this is going to be revealed in your reticulocyte count. So, because that really reflects the ability of the bone marrow to produce RBCs, which we've talked about. In the setting of anemia, you're going to expect to see reticulocytosis. In the absence of reticulocytosis or the presence of reticulocytopenia, that means there's an inadequate bone marrow response. So that's basically everything that's required for red blood cell production. Talk about some of the causes of anemia. So under blood loss here, we have acute and chronic. It's basically what we're splitting this up into, right? So your acute blood loss, in an adult, you're going to see greater than 1 liter drop before things are reflectively or reflected significantly in your hemoglobin. This is going to be uncommon in the primary care setting. Not saying you're not going to see it. One of the lowest H&H's that I've ever had come into the clinic was a 78-year-old female who came in with a chief complaint of, hey, I'm tired and I'm short of breath, can't walk from here to there without kind of feeling like I ran the Boston Marathon. This is a patient, by the way, who drove herself up to the clinic. She walked right in. She's sitting there. She's walking. She's what we refer to as a walkie-talkie. And I check a H&H on her, and it was in the gutter. She had a hemoglobin of, I think, 4 and some change, with a crit of 12 and some change. She was in fib, and so you're thinking, oh, okay, well, here we go. You're in atrial fibrillation. That's why you're so tachycardic. But again, I talk about tachycardia can be a symptom of underlying anemia. And her big issue was that she, when we started talking about some other symptoms, she'd been talking about how she's been having some blood in her stool recently. And so I checked a stool for guaiac. It was grossly positive. When I did a rectal and I pulled my finger out, it was covered with blood. And I also felt a nice big old honking mass when I violated her backside with my finger. So she was one who wound up being a malignant mass. So she had been had an untreated, undiagnosed, that's the first time I saw this patient, by the way, first time I ever laid eyes on her, untreated, undiagnosed carcinoma of the rectum. Still round and kicking, by the way. She's probably going to outlive all of us. It's amazing what she's been through, and nothing seems to stop this lady. But, all right, I digress. So that's acute blood loss. Again, usually uncommon in the primary care setting. And like I said, it is, however, a very common cause of sudden dangerous drop in hemoglobin and hematocrit. It can usually, again, be ruled out or in by health history and or physical examinations. That's why I just gave you the example of that one patient that I saw. Other thing we're going to have chronic blood loss. This is very common. You'll find this commonly in the clinical setting. It's usually from like an erosive gastritis, menorrhagia, or heavy menses, right? A GI malignancy. So that's some of the stuff that you're gonna run into. Iron from the red blood cells is being wasted via blood loss. It cannot be recycled. And you can have a clinically significant blood loss with just a few milliliters per deciliter. So that's just one thing to consider in terms of blood loss, acute or chronic. All right, other things. Reduced red blood cell production. So here it kind of talks about nutritional deficits. Some of the stuff that we talked about before that we need for red blood cell formation you're going to find. You're also going to find in the setting of anemia of chronic disease. We'll talk more about that in a minute. A lot of times people get confused with iron deficiency anemia and anemia of chronic disease. There is a way you're able to tell them apart. They present very much the same, but there's one thing that sets them apart. Bone marrow suppression, which is always scary. You can also, again, see this with reduced erythropoietin production. Again, your patient with chronic renal failure, end-stage renal, they're on dialysis. You can also see this in the setting of select medications that prevent micronutrient absorption. Let's think of your patients who are on a chronic proton pump inhibitor. Okay, that's going to affect B12 and iron malabsorption primarily. Metformin, believe it or not, very common. Our metabolic syndrome patients, right, our diabetics. Metformin is one of our frontline drugs. It can cause some B12 malabsorption issues. So just food for thought. Then we have premature destruction. So that's hemolysis. We've already covered that when we talked about LFTs. Talked about the role that liver plays in hemolysis and the lifespan of the red blood cell. I've already talked about that, 90 to 120 days. This is usually a relatively uncommon reason for anemia. Shortened red blood cell lifespan is usually part of the mechanism that you'll find in anemia of chronic disease. Which again I already mentioned we'll talk about because a lot of times it's difficult comparing that with it presents with an iron deficiency anemia. So, all right, let's kind of move along and let's talk about when you're looking at your hemogram, looking at the components of the red blood cells in your CBC. What's all that stuff mean? What are you looking at? What are you dealing with? Well, we'll start off with your H&H, something that you guys are already probably readily familiar with, right? So there's a ratio, 1-to-3 ratio of your hemoglobin to hematocrit. It's simple math. And if you have a hemoglobin of 10, you should expect a crit of about 30. Just multiply your hemoglobin by 3, and there you go. Hemoglobin, primarily iron-containing protein, responsible for transportation of oxygen. Hematocrit, that's reflecting the percentage of RBCs in a given volume of blood. It's also a value that's influenced by the body's hydration status. So in the setting of severe dehydration, you may see where this is artificially increased or elevated. Or someone who you've pounded a bunch of fluids into, or is fluid overloaded, again, you can see some artificial decrease in this, or what we call, you'll often hear referred to as dilution. So that's kind of what we're dealing with in terms of that. Next thing we're going to get to is red blood cell size. There's something called Weintraub's classification of anemia by evaluation of MCVs. I'll put up a algorithm here in a minute that really is one of the gold standards, and this is one of the things that we use to evaluate our different anemias is we look at the MCVs, rely heavily on them. So we're dealing with, in your MCVs, again, we're dealing with size, all right, mean corpuscular volume. So we break things down into 3 categories: microcytic, and you have your value there; normocytic, where things should be; and macrocytic. So small, normal, and large cells. One little clinical pearl that I'll share with you: if you have somebody who comes in that you suspect of being an alcoholic and you think they're lying to you about their alcohol consumption, and they don't have an underlying anemia, otherwise healthy patient, look at the CBC, and if you see that they are rocking an MCV count that's usually in the triple digits, usually 100 or greater, that means they've been hitting the bottle pretty hard. Main reason, again, we're dealing with size. Alcohol molecule is denser than any other molecule, so it causes an increase in the size of RBCs. So that's just an aside. All right, next thing we're going to deal with is we want to know what is the red blood cell's hemoglobin content. So we've got our mean cell hemoglobin, our MCH, and then our mean cell hemoglobin concentration, MCHC. So we're dealing with color here. Hemoglobin is the source of the cell's color. So we're dealing with chromic. So a lot of times we start off and we determine is something microcytic, normocytic, or macrocytic. Then we want to know, is it normochromic or is it hypochromic? So we're looking at color. There are your variations right there. So that's what you're looking at. So when there's an impairment of hemoglobin synthesis, we'll say iron deficiency anemia or maybe a thalassemia. Cells are going to be pale or hyperchromic, and therefore everything's going to be low. So next thing we kind of move on to, we want to look at your RDW, which is the RBC distribution width. It reflects the degree of variation in red blood cell size. Sometimes on a smear you'll see this reported as anisocytosis. If you see that at the bottom of your peripheral smear on your CBC. But anyway, it's when it's elevated, that means that RBCs are of varying size. So abnormal value greater than 15%. Again, there's varying size. Primarily, there's means that you have cells that were synthesized under varying conditions or varying times. We'll say in the setting of iron deficiency anemia, normal size cells are produced before iron depletion, and they continue to circulate throughout their entire 90 to 120 day lifespan. But this is comparing also old cells to new cells. It's one of the earliest laboratory indicators of an evolving microcytic or macrocytic anemia. So next thing we'll kind of take a look at is your reticulocyte count. And again, we talked about reticulocytes earlier as it relates to being one of the components that's required for RBC formation. Comes from marrow. So what we're looking at here is the body able or is it attempting to correct the anemia? So in normal response to anemia, you're going to see reticulocytosis. We mentioned that earlier. This is one of the most helpful tests in evaluating a person with anemia. And it's usually going to be elevated in the setting of, let's see, a hemolytic anemia, hemorrhage. It'll be decreased aplastic anemia, bone marrow suppression, or anemia of chronic disease. So let's talk about the different types of anemia. We'll start off with probably one of the most common anemias that you will see in practice. It's also the most common worldwide anemia, and that's going to be iron deficiency anemia. So again, worldwide, most common. But keep in mind, in terms of developed countries, United States, it takes on average, about 8 years of inadequate iron intake in adults before you're going to see an iron deficiency anemia occur. So it is a microcytic and hypochromic anemia with elevated red blood cells. And this kind of describes why. And here's what you're looking at. So again, if we're dealing with iron deficiency anemia, or any microcytic hypochromic anemia with elevated RDWs. Again, most commonly it's going to be iron deficiency anemia. You can also see it in chronic blood loss. One thing to remember, if a cell is small, if it's microcytic, it's always going to be small. So anyway, in this setting, we're going to have a decreased hemoglobin. We talked about our ratio, so crit's going to follow. That's going to be decreased. Your red blood cells, they're going to be decreased. Your MCVs, your mean corpuscular volume, that's going to be decreased. They're pale. We talked about color. So it's a hypochromic anemia, so that'll be decreased. RDWs are going to always be elevated. So everything's going to be down in the setting of a microcytic hypochromic anemia, except for your RDWs. Those will be elevated. So basically what's going on, iron loss is exceeding intake, so storage is depleted. The cupboards are bare at the store. So the decrease in iron is available for RBC formation. So this is usually slow in onset. As I mentioned, in adults, it takes about 8 years of poor iron intake or insufficient iron intake for this to show up. Again, presentation, fatigue, that's always going to be there. They may talk about worsens with activity or exercise, headache, may complain of palpitations, some weakness, some tachycardia. Again, so what do? We replace that iron, right? We have several different forms. We have oral forms, we have IV forms, right? You guys are all familiar with this. I've probably given this already in your various settings where you practice and where you work. So with oral forms, we're going to have ferrous sulfate, you're going to have ferrous gluconate, there's enteric-coated iron. So, but the goal here, what we're trying to do in the average adult, and a lot of replacement with iron is based off of age. So these numbers can change, but an average adult, they're going to need approximately 150 to 200 milligrams of elemental iron per day. That's kind of a key. We get into, and when you're given iron sulfate, you see, okay, I'm giving this patient 325 milligrams of ferrous sulfate. That's not all iron. In fact, with ferrous sulfate, you're giving them a 325 milligram tablet. About 65 milligrams of that is actually elemental iron. There's a liquid form as well that you'll often see commonly given. Usually comes in 220 milligrams per 5 ml. So 1 ml is going to equal 44 milligrams of elemental iron with ferrous gluconate. You're usually going to see those come in tablets of 240 milligrams or 324 milligrams. At the 240, you're getting about 27 milligrams of elemental iron, and at that 324 tablet, that's about 38 milligrams of elemental iron. And again, I said this changes, especially based on population. Elderly, for example, they need much lower intake of elemental iron. They can get by with as little as 15 milligrams up to about 150 milligrams of iron a day. So keep that in mind, and kind of look at and study and kind of know those differences. But you also need to teach your patients, don't rely on the pharmacist to do it, in terms of the side effects that are associated with oral iron. It can be very hard to tolerate. About 70% of patients who are taking oral iron replacement are going to complain of some GI side effects. So kind of coach them that that's going to happen ahead of time. It's really, really hard on the gut. Notorious for causing constipation, so you usually want to give those patients a stool softener when they are when they're taking oral iron. So other things you kind of want to look out for is keeping in mind that it is very dependent upon absorption. And we've talked about that before. We've talked about how PPIs, even your H2 blockers that you're given in the setting of GERD, can interfere with absorption of iron. Let's see other medications. Medicines for thyroid. We talked about that recently. So your levothyroxine, your Synthroid. You're going to want to instruct your patients to take that medication either 2 hours before or 4 hours after they take their dose of iron. Certain antibiotics, fluoroquinolones, and tetracyclines. So the fluoroquinolones, it's going to be your Cipro, right? Levaquin, moxifloxacin, Avelox. You want to separate doses by 6 hours. Tetracyclines, that's going to be your doxycycline, minocycline. Don't use concurrently. Separate by at least 3 to 4 hours. And again, believe it or not, some other common things that we give. We just talked about all your JNC stuff, right? So antihypertensives, especially ACE inhibitors, you want to try to separate those medications by about 2 hours. Don't give it concurrently. It can increase the risk of systemic reaction to iron, fevers, arthralgias, even hypotension. And then one thing that you guys probably already have learned is you need to avoid antacids. Decreases iron absorption, so separate by about 2 hours. One thing that you commonly will see given with iron is vitamin C. It greatly helps to increase absorption. So I usually instruct my patients to take it with orange juice. If I'm giving the liquid form, which is great, seems to be a little bit better tolerated GI-wise, and then especially for the elderly who don't need as much replacement as an average adult, you can actually instruct them to mix their dosage of their liquid iron into a glass of orange juice. So that helps tremendously. A lot of times people will ask, okay, what about IV iron? How do we know that this patient's going to need IV iron versus oral iron? It's not dependent on these levels here. It's really saved for patients that just can't tolerate oral iron. That's basically what it boils down to. Oh yeah, by the way, how long do you give oral iron for before we move on to your IV iron? typically you're going to get to where you can correct the hemoglobin and then tack on about 2 months afterwards. So. Anyway, so we're talking about IV iron. When should that be given? Again, that's primarily saved for patients that cannot tolerate the oral form. So elderly, I talked about, they're always a special population consideration. You can see it commonly in that. You can see it in patients that are pregnant. Anybody who has ongoing chronic blood loss, chronic liver disease. People who've had gastric surgery. Why? Because that inhibits absorption, right? And then speaking of which, anybody who has a malabsorption syndrome, sprue, or celiac. So that's kind of what we're looking for in terms of when we're giving our IV iron. Used to always be dextran that we'd give, very highly concentrated, which would lead to an increase of allergic reactions. Now we have stuff that's better tolerated in the IV form out there. Most commonly you're going to see used as IV Vinifer. There's also Fairlecit, Farinject, several others out there. Vinifer is going to be the most common. It seems to have gotten away from your IV dextran. So that's what we're doing in terms of response. We're trying to get, again, the cupboards bare. We're trying to get those stores replenished. So how do we know that those stores are getting replenished? And you're going to see anyone who has come in, you suspect anemia, you're going to order an iron panel. A lot of that's standard in labs. That's great. Not all labs will put this one lab in with their iron panel. Sometimes it has to be ordered separately. And that is going to be ferritin. So that is one thing, especially with lots of anemias, but especially with iron deficiency anemia, is you're going to want to check that ferritin because that's giving you an estimate of those iron stores, seeing if you're replenishing the cupboards. That's also, as I mentioned, you have all of this is very similar in presentation to anemia of chronic disease. The main kicker in anemia of chronic disease is that you're going to see an elevated ferritin level. With iron deficiency anemia, it's going to be low. Anemia of chronic disease, that iron level is going to be high. There's plenty of iron left in the cupboards at the store. So hopefully that makes some sense. Let's see. Let's talk about normochromic, normocytic, normochromic anemia with normal RDWs. So your most common etiology of that is going to be acute blood loss. Again, you're not really going to see that in the primary care setting. Or anemia of chronic disease. And you can also see it in select chronic inflammatory diseases, especially ones that are uncontrolled. So then here's an example of how that's going to look. Hemoglobin's going to be low, crits going to be low, your RBCs are also going to be low. MCVs in this case, they are normal. Color is normal as well. RDWs typically going to be normal. Not all the time, but most of the time. So these are cells that are made under ordinary conditions with sufficient hemoglobin, which therefore is going to yield cells that are normal in size, normal in color, and they're all going to be about the same size. So, with that, all right. I didn't mean for all that to go away. Oh well, all right. So with your microcytic hyperchromic anemia with normal RDWs, your most common etiology is going to be a thalassemia, alpha or beta thalassemia, minor. So at-risk groups for your alpha thalassemia, your AAA, Asian, African ancestry, a little mnemonic there. For your beta, there's this BAM, which is going to be beta, and then African, Mediterranean, or Middle Eastern. So it's normally an inherited genetic variation. As you can see over here, we get a decrease in hemoglobin, decrease in your crit. Red blood cells are actually going to be elevated. MCV is going to be low, MCH is going to be low because we know we're dealing with pale cells, so it's hypochromic. RDWs are going to be normal. Next step to test for in this setting is going to be something called hemoglobin electrophoresis. I'm not going to take the time to spell it out with my chicken scratch there. But just remember electrophoresis, hemoglobin electrophoresis for these people. And that's primarily, we're talking about the minors. Now there are major forms. The thalassemia majors can be life-threatening conditions. They're usually identified early on in life. It's going to be in your pediatric population. But otherwise, people with a thalassemia minor really have no particular health risks per se. So this brings us down to our macrocytic normochromic anemia with elevated RDWs. Most common etiology is going to be pernicious anemia, which is a dietary-induced vitamin B12 deficiency. I'm sorry, it's not. There's vitamin B12 deficiency. We see very commonly in pernicious anemia due to malabsorption. And a true dietary-induced vitamin B12 deficiency is actually fairly uncommon. And then you'll see a folate deficiency anemia. It's also not all that common. So your next step in terms of what you're going to want to check for if you suspect this, you check a vitamin B12 level, right? And you're also going to check a folate level. Again, some of this stuff's included in iron panels and iron workups, but depending on where you're going to be working at or practicing at, not necessarily, especially ferritin, B12, and folate. So things to kind of consider when you're dealing with these two issues. Especially, let's say, folic acid. You can see that in your elderly, your alcohol abusers, impoverished persons, people with a decreased ability to absorb folic acid, the malabsorption syndromes I've talked about earlier, such as sprue and celiac disease. You need to look out for this in the setting of pregnancy, because folic acid readily transfers through the placenta to the fetus. So in a patient who has repeated or multiple pregnancies, in particular, this can cause a depletion of maternal folate stores. So usually largely avoided with consistent use of what? Prenatal vitamins. Have high folic acid content in it. But you also need to have these patients, especially if they're going to be breastfeeding, continue supplementation. Because about 0.5 milligrams per deciliter of folic acid is transferred to breast milk. So, and maternal folic acid deficiency is also a teratogenic state, so it can lead to birth defects, primarily in the neural tubes. So you need to keep that in mind. Regular outside of that, folic acid replacement in adults typically ranges from 0.5 to 5 milligrams, the usual dose being 1. Usually kind of repeat your labs in about 1 to 2 months, and you should start to see a resolution of that, and that the folic acid deficiency should resolve. Now B12, a little bit different. Again, we commonly see it in the setting of pernicious anemia. There's atrophy of the stomach. Secretion of intrinsic factor tends to cease. Diet alone is not going to really get you there, because plants and animals are not independently capable of constructing the vitamin B12. So this, and again, when I talk about the overview of anemia with B12, a lot of this you can have some neurologic signs associated with this presentation. So you may have a patient that comes in complaining of neuropathy sort of symptoms, maybe some difficulty with balance, some memory changes, some oral irritation, maybe even some mild scleral icterus. So keep that in mind in the setting of a pernicious anemia. Also in the setting of pernicious anemia, when you start correcting this, you need to pay close attention to potassium. Reason being is that reticulocytosis is very brisk in these patients. A hematological response is pretty rapid after therapy has begun. Reticulocytosis usually peaks within less than a week, 5 to 7 days. So you can see hypokalemia caused by serum to intracellular potassium shifts. More common if the anemia is more severe. So you definitely want to be monitoring potassium daily during the first week of therapy, especially in patients that are getting diuretics, or say someone, what else interferes with potassium? DIG, someone who's taken digoxin. So if hypokalemia occurs in these patients, you're going to want to put them on oral replacement at 40 MEQs a day. That's usually sufficient. Sometimes you have to do oral iron therapy if there's an underlying iron deficiency or low iron stores, low ferritin levels. Full recovery usually takes about 2 months or so. So for just standard B12 replacement, someone's low on B12. There's also a very brisk hematological response, and again, usually resolves within about 2 months. However, the reversal of some of those neurologic abnormalities is usually a little bit slower. There's oral and injectable forms of B12. A lot of the stuff's over the counter, sublingual drops, so on and so forth. The parental form is preferred due to the fact that it's better absorbed, tends to be better adherence. And of course, in that form, we're talking about the injections, B12 injections. In the oral form, B12 is more erratically absorbed, especially in the small intestine. So that can lead to treatment failure. There are some studies out there that show that the sublingual drops are better absorbed, but jury's still a little bit out. So if you're going to use the injection, you're going to do 100 micrograms a day IM times 1 week, then weekly for the first month, and then monthly after that. Then you will see doses as high as 1,000 micrograms used per injection. But and whoever's doing that is actually really wrong in the way that they're prescribing it, because a dose greater than 100 micrograms in a single injection really exceeds the binding capacity of transcobalamin. And so the rest of it is basically just kind of excreted and filtered out by the kidneys and goes out through the urine. So, oral dosing, you're going to want to do 1,000 micrograms a day. Again, higher dosing on the oral side because we talked about absorption can be an issue. Again, there's sublingual dosing. We've talked about that. There's even a nasal gel that's out there, or nasal spray. That's usually dosed at 500 micrograms. And again, sometimes you're going to need oral iron therapy to go along with it if there's underlying iron deficiency and we have low iron stores. So again, you're checking that, monitoring the stores of our iron through what? Through a ferritin level. All right, anemia of chronic disease. Actually, sorry. I need to back up. I need to cover this last one here. The drug-induced macrocytosis without anemia. So again, the keys here, you find what the underlying etiology is. There's a list of different drugs that are used. Usually this is reversible when you just take away the offending agent. Fairly simple. That's how that's going to present. So again, look out for these drugs. They're the main offenders. So anemia of chronic disease. Again, this is going to be something that's you're going to find commonly in people that have chronic health problems, chronic inflammatory issues, whether it be infection, arthritis, renal insufficiency, hypothyroidism, cancer patients have malignancy. Overall etiology is somewhat unclear, but it does involve just decreased erythrocyte lifespan. It's the second most common cause of anemia, your anemia of chronic disease. Symptoms can be similar to what we've talked about before. Again, the big kicker where you are able to identify that this is not iron deficiency anemia is that ferritin level. It's going to be low in iron deficiency. It's going to be high, greater than 100 in anemia of chronic disease. So main thing that you're doing is you're treating the underlying cause or the underlying chronic disease state that's going on, provide nutritional support. Sometimes patients with end-stage renal or HIV, they're going to need some erythropoietin. So that's pretty much it. And this goes for all anemias, by the way. Treat the underlying cause, replace needed micronutrients, and here's your EPO or your Procrit as indicated in the settings that we talked about, particularly advanced renal issues. You're going to see that. One other one, just kind of touch on quickly, sickle cell anemia. It's a chronic hemolytic anemia, and again talked about hemolysis and hemolytic anemias you don't see all that commonly. Sickle cell is probably the most common of that, though. It's usually an acute exacerbation period in which RBCs become literally, they look sickle cell shaped. When you look at it on a smear, it causes vessel obstruction. There's cellular hypoxia. That results in acidosis and tissue ischemia. That's why these patients have a lot of pain due to that ischemia. Factors that can kind of precipitate that: hypoxia, infections, high altitudes, don't have that issue here, dehydration, recent surgery, blood loss. Usually the signs of this disease usually develop in infancy or childhood. Going to see delayed growth and development, increased susceptibility to infections. When these patients come in and when they're having a big crisis, it's a sudden onset of severe pain, usually in the extremities. You can also see it in the back, in the chest, or in the abdomen. They're going to talk about how they ache and hurt all over. They're going to have weakness. They're going to have dyspnea. So you're going to give analgesics, obviously, for the pain. You want to correct that hypoxemia, if that's the case, with oxygen and fluids for dehydration. So that's kind of pretty much it for sickle cell. Other thing that you need to know about that I posted, and you can read it. It does a very good job of explaining it. I think it's from the AAFP, is discussing leukemias and lymphomas. Also make sure that you know your T&M classification of malignant tumors. You may very well see that again. The T is scored as that's your size or the direct extent of the primary tumor. The N number is any spread to any regional lymph nodes, and the M is for distant metastasis. So it's right there in the name, the T and M. T for tumor, N for nodes, M for mets. So look that over and make sure that you're familiar with that and you've kind of gone over that. So, kind of skipped around a bit. Anemia is kind of a big thing, but I hope that kind of breaks it down a little bit easier for you, makes it a little bit easier to understand following this, following these sheets. and what we talked about and kind of what to look for. Last thing that I want to put up real quick regarding anemia, I talked about one of the key things that we use for treatment algorithms is based off of the MCVs, the mean corpuscular volume. This is from Up to Date. So you have anemia is detected on a CBC, and again, it's another thing. A lot of people come in and they say, if you are you drawing iron panels? Are you checking every patient who comes in the door and says that they're tired for anemia? Not necessarily. Like I said, I'm going to check a CBC, but I'm not going to do a full-blown anemia workout unless I have a very high suspicion or there's a previous history or something to that effect. You're going to start with just your CBC. And the reason being is that in most cases, labs, they will hang on to blood for typically about 72 hours. So if your CBC comes back and you're suspecting or it reflects an underlying anemia, you can simply call the lab and have them add on other studies to the blood that they already have on hand. So if your MCV is low, we already defined that earlier, less than 80, next thing you're going to do iron studies. Like I said, a lot of labs will just have an iron panel. So you're going to have your serum iron in that. You're going to have TIBCs. Not all the time, though, is a ferritin going to be included in an iron panel, depending on the lab. You want to check where you're at and see if they automatically include that or not. If they don't, then please make sure that you order that separately. So this basically kind of shows you if you have a low serum iron, high TIBCs, low ferritin, you're likely dealing with iron deficiency. Determine the cause and treat. So if you have a low serum iron, a normal or low TIBC, or a normal or high serum ferritin, it's likely going to be anemia of chronic disease. Again, that's that high ferritin. That's how we differentiate these two, right? Or it could be infection, inflammation, and malignancy. And then finally, lastly, over here, if you have a normal or high iron level or normal to high ferritin, then you start looking at sideroblastic anemia. I didn't go into much detail about that. You can read briefly on that. This is very uncommon. This is not fun stuff. Or you could possibly have a thalassemia, and again, you're going to check that electrophoresis to find out. So if you have a normal MCV, you're going to look out for, make sure you're looking at those reticulocyte counts. Make sure there's not any bone marrow suppression going on. Check your BUN and creatinine, see if there's any underlying renal insufficiency if you're suspecting anemia. There's red flags. Hemolytic anemia could be going on. And then over here, if you have elevated MCVs, a lot of this stuff's going to be automatically, they'll run a smear, and you'll be able to catch that. But otherwise, you want to check a B12 and folate level. All right, we already talked about the settings of that. Pernicious anemia, B12 deficiency, folate deficiency. B12 deficiency, find to treat and determine the underlying cause. It's folate, treat, determine the underlying cause. Remember your pregnant patient population here. And then other causes can be drug-induced, right? Or we know that list of drugs. Chronic liver disease, we've covered that already, and we've talked about with thyroid disorders as well. So that's kind of your treatment algorithm. Those are the things that you can work up on your own too before you send off to hematology. It'll also make their lives a lot easier as opposed to you just check a CBC and because you now are an expert on identifying anemias and the CBC comes back and it shows that they have a low hemoglobin, low crit, low red blood cell count, low MCVs, low MCHC, and elevated RDW. What am I describing? A microcytic hypochromic anemia with elevated RDWs, most commonly going to be iron deficiency. Don't just send that patient off with just a CBC to hematology for them to further work up and evaluate and treat. Again, do your iron panel. Check that ferritin. There's things that you can do before you immediately have to send off and refer. One other thing while we're talking about red blood cells, this is the last thing, I promise. I know this has run a lot longer than I thought it would. Something called polycythemia vera, or polycythemia vera, PCV. That's going to be an elevated red blood cell count, elevated hemoglobin, elevated hematocrit. Okay, blood starting to thicken up. You see this very commonly in your COPDers. You see it commonly in your smokers. So it depends on degree of elevation. Like I said, this is often just part of the chronic disease state of tobacco abuse and COPD. But if levels start getting too high and blood starts thickening up, that can be a problem, right? It increases our risk for what? Clot, right? So we need to thin that blood out. So a lot of times, a lot of these patients, if their counts are really high, you will refer them to hematology so that they can undergo phlebotomies and have treatments to help thin out that blood. Also, maybe baby aspirin on board, not a bad idea. But you don't want to let that blood get too thick. You don't want to let that polycythemia linger for too long and those levels go up too high because there are obviously major cardiovascular risks, which is part of these knuckleheads smoking in the first place, and that's what one of the main things we have to guard against along with lung cancer. So, all right, that pretty much wraps things up for anemia. Hope this was helpful. As always, any questions, email me through D2L, call or text me. And hope you have a good week.